Good afternoon, everyone, and welcome to the California Black Health Network's first Health Equity Forum of 2024. I am Rhonda Smith, the Executive Director of the California Black Health Network, and thank you all for being here today. So our session today is focused on the National Institute of Health, or NIH's All of Us research program, because I believe it will take all of us to work together to end health disparities. And we are very, very honored and fortunate to have Dr. Kareem Watson, Chief Engagement Officer for the All of Us program, as our featured guest today. So Dr. Watson will give us an overview of the All of Us program, talk about how the program works to advance health equity, and also about the importance of community engagement through the community and participant engagement framework. We at the California Black Health Network want better health for all of us. And the thing that I like the most about the All of Us program is that it aims to make precision medicine, which is the type of healthcare that treats every person as an individual, as a means to achieve health equity. So I hope that all of you will be able to take back some important information to your community and loved ones about the All of Us program and encourage them to learn more, as well as sign up and participate and enroll in the program. So before we hear from Dr. Watson, I'd like to take a few minutes just to go over some housekeeping items. So the chat box is available for you to say hello to people that you recognize in the participant list. And if you have any questions, please put them in the Q&A box at any time during the session. Everyone will remain muted, and then we'll have an opportunity to drop your questions or entertain your questions after Dr. Watson's presentation. So before we hear from him, I just want to take a few minutes to go over some things about the California Black Health Network for those of you who may not be familiar with the organization. So we are the organization that is the voice and trusted resource for Black Californians. We are the only statewide Black-led organization that is dedicated to advancing health equity for all African American and Black immigrants here in the state. And what we do is conduct research, outreach, education, and advocacy, as well as programmatic work to achieve health equity for Black Californians, really doing that through the lens of understanding the critical issues that lie at the intersection of racial justice, social justice, and environmental justice, which is our health equity framework. Next slide, please. And so our vision is to create a California where every African American and Black immigrant has the opportunity to live a long, healthy life that's free from violence, racism, and health inequities. And we work very hard to do that every day, to ensure that all Black Californians, really, regardless of their education level, how much money they make, where they live, who they love, or how they identify, or even where they're from and their housing status, really has the opportunity to access high quality, equitable primary as well as behavioral health care, and definitely avoid succumbing to diseases, especially those that are avoidable. And so I won't prolong the introduction to Dr. Watson, but just to give you a little bit more information and background of who Dr. Watson is. Again, he is the Chief Engagement Officer, for the All of Us program. And in that role, he leads the program's effort to foster relationships with participants, communities, researchers, and providers across the country to help build one of the largest, most diverse databases of its kind to study health and illness. Before he joined NIH, Dr. Watson spent about 15 years as a community engaged research scientist, supported from NIH funding to address cancer prevention and control. He also held administrative roles in leading research and engagement in federally qualified healthcare centers, or FQHCs, in the Chicagoland area. So Dr. Watson, there's a lot more I could say about you, but happy that you're here today, and we'll turn it over to you to share the information about the All of Us program and what that's all about. So thank you very much.
Thank you so much for having me. Can you hear me okay?
Yes, we can.
Okay, great. Thank you. And really happy to be here. And I'm happy to be here as we, I celebrate Black History Month 365. But, as we think about African American History Month, and just the time that we have and where we are at a time in our country, it's really an honor for me to be here today and to share with you the All of Us Research Program. So I also want to make sure that I'll do a presentation, not a presentation, but present to you the All of Us Research Program for about 30 minutes or so, 40 minutes maybe. But I also want to make sure I leave time for questions and answers and for dialogue. I was seeing some comments in the chat, so if there's a way I can make sure that we're communicating in the chat. And I also want to acknowledge a couple of my colleagues that are here with me. They're in the general audience, but Sheila James, who is one of our program officers here at the All of Us Research Program and who is a Californian and is located in the California area. So really happy that Sheila James is here with us. And Angeli is from our visibility team is here supporting us as well. So I want to thank our team for being here. Without further ado, I'd love to talk to you about the All of Us Research Program, our journey to health equity, and why it will take all of us. Next slide. So what I hope to accomplish today in the next 30 minutes or so is to introduce to you all the NIH, the National Institutes of Health, All of Us Research Program, and discuss the role of genomic data, what it plays in underrepresented communities and the role it plays in advancing health equity research. And then I also want to highlight the importance of community engagement through our community and participant engagement framework and some work that we've been doing with partners. And I'm intentionally going to highlight the work of our African-American partners that we have within our engagement system and throughout our program. Next slide. So what is precision medicine? What is all of us? So I have to start with this quote from former President Barack Obama from the State of the Union address in January 2015. I'm going to read it verbatim. He said in that State of the Union address, "Tonight, I'm launching a new precision medicine initiative to bring us closer to curing diseases like cancer and diabetes, and to give us all access to the personalized information we need to keep ourselves and our families healthy." You think of this concept of precision medicine, really in a nutshell, what it is understanding that we've moved from this disease-focused concept of a one-size-fits-all approach for medicine. Gone are the days where we think of someone having cancer, for example, and we give everyone the same chemotherapy, not thinking about family history, not thinking about ancestry, not even thinking about where they live, their zip code. One of my mentors, Dr. Robert Wynn, coined the phrase ZNA, zip code neighborhood associations. We talk a lot about DNA, what we're born with, our genetics, but Dr. Wynn encourages us to think about our ZNA as well, where we live. Because I'm actually located in the Chicagoland area, and my parents are from the South, like many folks that we know in the book in the Warmth of Other Suns and other books like that. We migrated up north. My parents migrated from the Deep South up north to Michigan looking for job opportunities in the automobile industry. And that landed us and several of my uncles and for my dad's family in the Michigan area. But they fled the segregated South, coming up north for more opportunities. So germane in all of our families is the concept that our zip codes matter. Where we lived for history has determined how free we could be, what we had access to, what things that were able to be within our reach. So our zip codes have always played an important role. And there's no difference when it comes to our health, unfortunately. Living here in the Chicagoland area for over 25 years now, actually 22 years, moved here for graduate school. And in the Chicagoland area, and I'm similar, this is true in the California area, health disparities can change. Life expectancy can change 20 years, meaning that in one of our community areas here in the Chicagoland area, life expectancy is around 85 years old in the area we call the Gold Coast, which is a more affluent neighborhood. You take 2 train rides on one of our CTA trains, our Chicago Transit Association trains, and that life expectancy in the African-American community nearby drops 20 years to 65. That is a demonstrative of the fact that where you live can inform your health outcomes. So again, this is what precision medicine is trying to take into play. I also am very open about my own family history because one of my friends and colleagues, Candace Henley, a colon cancer survivor or thriver, as we like to call her, and founder of the Blue Hat Foundation, she has a mantra that says that family secrets kill families, particularly in our African-American community. So I'm very open about my family history with living with cancer and how the fact that I lost my birth mother to breast cancer when I was 6 and my dad remarried and my new mother even got cancer. My dad was able to navigate through my new mother's diagnosis differently because of what he dealt with my birth mother's diagnosis of breast cancer. And fast forward 20 years later, I'm in graduate school getting my NPH, and my oldest sister gets breast cancer. And medicine was not precise for her because although the providers knew she had a history of breast cancer and genetic testing was done on her tumor to determine what treatment she should get, there was not genetic counseling wasn't done. There was no discussion about family history and what that meant for my other sisters and what screening they should be getting. So this concept of precision medicine is something that I live and know oh too well. I saw it also firsthand with my oldest brother, who was diagnosed with colorectal cancer several years ago. My oldest brother was also a kidney transplant recipient. So that meant that when he was facing his second battle with colorectal cancer, the type of chemotherapies that he could get or was available to him had to be tailored to make sure that they didn't impact his kidneys and his other health. Unfortunately, my brother passed away from complications of colon cancer. And as a cancer disparities researcher, I hear that story oh too often. And so I know firsthand. So again, what is precision medicine? It's the understanding that not a one size fits all approach matters. It's understanding that we must take into account someone's family history, someone's ancestry, race, even understanding and acknowledging that race and ethnic race is a social construct, but still the way we self-identify can play a role in our health outcomes and what we have access to. And also understanding the impact of food. All of these things fit under the umbrella of precision medicine. So in January of 2015, President Obama announced the Precision Medicine Initiative during his State of the Union address. And in March 2015, the NIH announced the establishment of the Precision Medicine Initiative with a working group. And in September 2015, the PMI working group published a report on Precision Medicine Initiative. And in 2016, funds through the 21st Century Cures Act, enacted by Congress and signed into law, put into place the research agenda that we now see and now call part of that is the All of Us research program. And so excited that All of Us is looking to gather a longitudinal effort to gather information from 1 million or more participants across the US. And unlike some research questions that are looking to see if a new drug is better than an existing drug or looking to see if a new procedure will be better than another one, All of Us is looking to gather data from 1 million or more participants that will be used by other researchers to answer questions and to make sure researchers have access to that data. So I'll talk a little bit more about how All of Us differs from other research programs in a second, but next slide. I want to ground this. I can't talk about the importance of returning value and the importance of history. So I want to early on start off with this photo because this photo represents a historical moment. This photo is actually a picture of an event, the Health Research Symposium called Moving Us Forward in Macon County, Community Convening in Tuskegee, Alabama, that took place last year during African American History Month, February 9th through 10th. And the reason why this convening was so important because it allows us to address historical trauma head on by discussing the United States Public Health Service study of untreated syphilis in the African American male and the story of Henrietta Lacks. Many of you may know about this study, may call it the Tuskegee experiment. Well, actually, one of the things we found out doing that community convening is that the members of Tuskegee, Alabama, don't want us to call this study the Tuskegee experiment because that puts a negative connotation on Tuskegee when actually the study was a U.S. sponsored study, U.S. government sponsored study, U.S. Public Health Service study looking at untreated syphilis in the African American male. And I start with this because this was a historical moment for us where we convened over 300 people in the Macon County area. And we worked with the great granddaughter of Henrietta Lacks, Veronica Robinson, in the blue suit. We worked with one of the last surviving members, the descendant of one of the last participants of the U.S. Public Health Service study of untreated syphilis, Miss Lily Head, whose father was in that study. And it was so important to bring them together and to bring them together in Tuskegee, Alabama. And that picture you see on the right there is us with several faculty members, as well as geneticists and researchers. In that picture, we have Dr. Clayton Yates, a known researcher looking at cancer disparities researcher, basic scientist, who looks at African Americans and the African diaspora and prostate cancer. We also have Dr. Faith Fletcher in that picture. We have a former mayor of Tuskegee, Alabama in that picture. And because that picture is so important, because several of those partners have come together to continue to have conversations about what does it mean for community members of Tuskegee, Alabama to be a part of precision medicine. And I want to read a quote to you from Dr. Thomas from the Atlanta Journal-Constitution, where it says, "Moving from promise to progress, family members of victims of the well-known medical transgressions speak with health leaders on working to regain trust." And that whole concept of regaining trust is so important in precision medicine, but also what's important is becoming trustworthy, making sure that we create spaces and places for the systems to be more trustworthy and acknowledge what has happened in the past. Next slide. And another thing that happened in this convening is that we want to make sure that you have to make sure the resources are there and conversation continues. So we made sure that we worked with one of our organizations called Pyxis Partners to ensure that we funded new partners in the Macon County, included the national, a member of one of the sororities there that works specifically with the Black nurses in the county, but also the Macon County Healthcare Authority. And also, who knew that Macon County had its own IRB, its Institution Review Board, that reviews and prioritizes what types of research that it wants to see coming out of that community there. And it was so important for that work to be led by Dr. Stephen Sodeke, a African-American bioethicist at Tuskegee University. And it was important for that convening to happen in a faith-based setting, because we know the importance that the faith community has historically played and still does play in the African-American community. So again, this concept of moving us forward. Next slide. So All of Us by the Numbers, this is a map that actually shows where the All of Us research study is taking place across the US. And every single state is highlighted because every single state across the US and US territories has engaged in enrolling a participant in the All of Us research program. But one of the leaders, no surprise, is California. So I'm really excited to be here today because to date, California has enrolled over 71,600 participants in the All of Us research program. So the California Black Health Network plays such an important role. And I'm so excited to be meeting with Rhonda later on, in the upcoming weeks to talk about how can we even be more intentional in working with partners in the state of California to discuss this concept of precision medicine. Because what is our goal in All of Us? Our goal is to enroll 1 million or more people who represent diversity of the US. And from those 1 million or more participants, we want to collect information, not just genetic information, where we're looking at biological information, our DNA, our genetics, and our ancestry, but we also want to collect information through that electronic health record that will give us a bigger picture of what that person's health history has looked like. In addition to that, we also want to make sure we're collecting survey information, where participants are completing information around social determinants of health. And I'll talk a little bit more later about the questions that we're asking through that SDOH, our Social Determinants of Health survey. But this is so important to understand that All of Us is beyond not just collecting biological samples. And to date, we have over 767 participants. Over 425 participants have agreed to donate their health record. Over 500,000 participants have participated in our surveys. And we have over 500,000 biological samples collected, making us to date the largest and most diverse genomic data set in the world. Next slide. And this is just a snapshot of the All of Us California Consortium. To date, those partners include UC San Diego Health, UC Irvine, UC Davis, UCSF, Cedars-Sinai, the University of USC, as well as a partnership from Yale that is also a part of that All of Us California Consortium. So as you can see, California has a huge footprint in the All of Us research program. Next slide. And our participant diversity. At the top of the opening, we talked about the importance of African Americans participating in research. And one of the things I want to note is on this slide. This is actually a pie graph that shows historically what genomic studies look like. You'll see that large blue circle on the right here. This is other genomic studies. Historically, only about 0.5% of participants in genomic studies have been African-American or Afro-Caribbean or African, and then only about 0.2% have been of direct African descent. And when you think about Hispanic and Latinos, that's even 0.35%. Asian Americans, a decent representation, but it still doesn't reflect the population with 3.72%. But historically, our genomic studies have been majority over 94% representing white or European descendants. And what does that mean when it comes to generalizability of the data that we find? I'll give you a concrete example. When we're not involved in certain studies, this demonstrates what we're not able to do in terms of how things may impact our community. A concrete example I like to give is the example of the HPV vaccine trial, human papillomavirus. So some of you all may know that cervical cancer is actually one of the few cancers that is associated with a viral component, the HPV virus. And as a result of that amazing scientific discovery, understanding that a cancer that affects women, people assigned female at birth, understand that that cancer affects women, and particularly women of color, disproportionately, and knowing that it has a viral component connection to it, the scientific community was ecstatic and excited when a vaccine came out that can prevent HPV or decrease the likelihood of HPV, the virus, turning into more an aggressive form of the virus that will cause, cervical cancer. But when this research came out, because that study lacked diversity, racial ethnic diversity, the vaccine only covered 2 strains of the HPV virus. We heard a lot about strains during the COVID-19 pandemic, right? We kind of learning that viruses have different strains. And when we develop vaccines that target multiple strains. Well, the HPV vaccine targeted 2 strains, but the research that we found, those strains were not the strains that were more common in African American and women of African descent, and even Hispanic and Latino women that were more likely to have other strains that would progress to cervical cancer. So we're promoting a vaccine that wasn't even possibly applicable to prevent and mitigate disease in high-risk African American women. So I'm so thankful that there was a researcher at Duke University, actually an African American woman, who said, wait a second, we need to make sure that we're looking at the African diaspora data across the globe. So with advances in research, they found that other strains that were more common in cervical cancer in African American and women of African descent, now we have a vaccine that actually covers about 9 strains. It's like a 9-valent strain of the vaccine that covers 9 different strains. And now some of those strains that are covered are the strains of that virus that we see impacting women of color more regularly. That's the advance that research can have. But if we're not at the table, those advances won't benefit us. And so I'm really excited to say that the All of Us research program has achieved unprecedented numbers in diversity, equity, and inclusion, because it's just beyond race and ethnicity. But in terms of race and ethnicity self-identified, we have almost 16.8%, almost 17% of our participants self-identify as Black or African American or of African descent. And that's an amazing feat. Actually, before the pandemic, we actually had about 20%. So while this number is great and it's unprecedented, we still have more work to do. Next slide. And Rhonda mentioned this earlier, and thinking about that intersectionality, meaning our multiple identities. So in addition to prioritizing race and ethnicity and self-identified race and ethnicity, our program is the largest program of underrepresented participants in biomedical research, meaning that we have over 47.9% of our participants are diverse in terms of race and ethnicity. But about 1 in 4 of our participants is greater than the age of 65. Why is that important? Because historically, research that has taken place has not accounted for the aging of America. It hasn't accounted for the fact that as we get older, we may be susceptible to more conditions. Because historically, research has included healthy, younger, white populations. So that means that drugs that are developed on populations that don't carry the greatest burden of disease. And even also those studies often are done in populations that have a higher SES, socioeconomic status, income. About 1 in 4 of our participants has an income, annual income less than $25,000. We also, the intersectionality of people living with disability. Population living with disability is one of the largest and growing minoritized communities in our country. About 1 in 5 Americans is living with a disability. And as chronic diseases continue to evolve, we will have more Americans living with disabilities, those disabilities that may be seen as well as unseen. Some cognitive disabilities that may come about from untreated cardiovascular disease and untreated, cerebral vascular disease, stroke, and other things associated with the brain. So really important for us to think about this concept of intersectionality. Also thinking about sexual gender minorities. Our data set is the largest secondary data set of sexual and gender minorities in the country. That is saying something. That's saying that, when we think about research findings that have been unintentional about including populations that are marginalized, we, through intentional efforts, have included those populations. And even geography, thinking about rural populations, 7.8% of our participants are from rural communities. And when we think about this, we also think about this concept of, yes, that's how people identify, but then we also have our social determinants of health questionnaire. I'm going to do a deeper dive with this, but imagine the power of having someone's genetic information also in line with and having access to how that person lives and operates their neighborhood environment. What type of social support do they have? What types of languages do they speak? What type of stress are they under? Food insecurity, housing, healthcare access, and discrimination even. You know, social the social support that you have, even religious attendance and spirituality. All these things come into play when we think about our holistic definition of wellness. So one of the things that our study does, and I'm proud of, is puts this data in a one-stop shop, if you will, so that researchers no longer have to look at this database to answer a biological question, this database to answer a social question, this database to answer a question about stress and diet. We try to put that data in a one-stop shop so researchers can have access to that data and ask questions that they have not been able to ask before because that data is convened in one place. Next slide. And all of us health equity vision, I want to give credit to Dr. Martin Mendoza, our Director of Health Equity, for his development of our health equity strategic vision. And within that, he looks at EDIA, not just health equity, but thinking about equity, diversity, inclusion, and accessibility. So within that, at that base is the All of Us Equity vision. And All of Us catalyzes scientific breakthroughs to advance precision medicine and health and achieve health equity. That is our goal. And we do this through programs and administrative equity-driven decision-making. Dr. Mendoza is at the table asking us tough questions about, okay, yes, this population has been included, but who have not been included in our population? So really embedding health equity across all aspects of the program. And then when we think about the All of Us program is also dedicated to advancing the science of health equity with the focus on populations who have been underrepresented, also in the biomedical research and the workforce. One thing that I like to say is that the messenger matters. When I spent 17 years at the University of Illinois at Chicago, UIC, conducting cancer disparities research, my peers would often comment and say things like, well, Kareem, you do research with African-American men, and they called African-American men a hard to reach population, a phrase that I actually hate, because I say, you know, I never have a hard time reaching us. A, I am one, and B, I go to where we are. So I've never had African-American men be a hard to reach population. And why was that? Because my research went into the community. I worked with barbers. I worked with barbers and trained them as citizen scientists. I worked with fraternity members. I worked with pastors. I worked with civic organization leaders, and who had the trust of the community and used those trusted messengers. And I also had a team. My research team looked like the community that we were talking to. I just talked to one of my former students yesterday, who's a PhD student in EpiBio at Tulane University. And I was talking to the student about the importance of him staying in the game, because it gets tough when you're in one of those doctoral training programs. But I told him it was so important for him to stay in the game, to continue to get training, to become a researcher, because the messenger matters. There is scientific evidence that shows that cultural congruency, meaning when the researcher and the research team matches the population that you're working with, that you have greater buy-in. Right? That makes sense, right? The message, because we bring our full selves to this work and our lived experience. I don't have to think about some of the issues of, I don't have to just read about in the literature issues of medical mistrust. I know what it looks like. I can talk to my family. I know what that looks like. Some members of my family were not excited when I told them I was going into research as opposed to medicine, because they knew, they're from the South, and they knew the historical trauma that had happened. And they were like, are you sure this is what you want to do? And I said, yes, because it's not good enough just for us to have a seat at the table. We have to own the rooms. We have to be the one developing the research questions. So yes, I'm sure that I want to be a part of advancing research in this way. So I'm so happy that Dr. Mendoza put it this way. And then at the top of achieving health equity, we understand that health equity is the fair and just attainment of the highest possible outcomes of health for all of us. So if there's members of our community that don't have health equity, we are still in the struggle. I'm very fortunate and very thankful of the things that I've been able to achieve. But when I look across the street on the South Side Chicago neighborhood that I live in, and I see that just by going across the street, someone's health outcomes can change, we still have a health equity agenda and focus that we need to be relentless in making sure that we achieve that. So thankful to Dr. Mendoza on this. Next slide. And another thing that we want to make sure is that we're embedding health equity in our investments, in our decision-making, creating and supporting uncharted paths for this, and also to continue to bring our community participants and researchers' voice into the table as we make these decisions. Next slide. Next slide. So reaching communities through a robust community engagement network. So one of the things that I do is, again, I said, I'm trained in a particular type of science called community-based participatory research, CBPR. And what that means in a nutshell is that the research that I did and that I used to do was informed by the community and always had a community partner alongside me doing that research. And so I'm so thankful that the All of Us Research Program has adopted and developed many principles of community-based participatory research and principles of community engagement. And we have an engagement ecosystem that includes over 18 community partners. And I highlight 3 here that are very important to engaging African Americans. When I think about Delta Research and Education Foundation, DREF, as many of you may know, DREF is the not-for-profit arm of Delta Sigma Theta sorority, the second oldest African American sorority in the country. Imagine the impact of what we can do having DREF as one of our partners. Another one of our national engagement partners is National Baptist Convention USA. There is evidence and data that shows that spirituality is in the faith community is still an important part of the African American experience and African American culture. So having National Baptist Convention USA as one of our partners has been amazing. Also, a partnership with Dr. Consuelo Wilkins at the Vanderbilt University Medical Center has been amazing. Dr. Wilkins leads an African-American internist. She leads our works with participant ambassadors. We work with participants as partners. But all of our partners throughout the 18, all of our national 18 engagement partners address some level of intersectionality. Next slide. And within our vast network of our community partners, we also have an organization, one of our partners called Pyxis Partners. And what Pyxis has done is allowed us to expand that network to over 115 community partners, including the Black Greek Letter Consortium, the BGLC, including organizations like the Y and several other organizations that allow, even working with some HBCUs, historically Black colleges and universities, that allow us to leverage the trusted presence of several community partners in this network, allowing us to do this work and move this work forward through our CPGI network. Even some of our partners from Dallas, one of our community partners from the Dallas area, the Texas area, is here today. So I'm thankful for that reach beyond what we're able to do through our community partner network. We have other partnerships, even through the National Rural Health Association. Next slide. And I believe that engagement is a science. I believe in community engagement is a science, just like genetics is a science and just like other things. And we take a very intentional approach in how we engage community members. We engage through outreach and awareness, thinking about those interactions focused on fostering trust, providing materials and informing information. We also engage through education and access, understanding that we still have to inform and educate communities about the importance of participating in precision medicine research. What is precision medicine research? And then thinking about how do they have access to those research studies? Because too often research studies take place in what we call ivory towers or big academic medical centers, instead of really taking place in the communities where populations live and where they have access to those research. And then engage to enroll and retain. You know, it's not just enough to provide access. We also must make sure that for our enrollment partners, that we're working closely with them, that the enrollment experience and the retention experience is one of equity and inclusion. And then once you enroll in our program, there's an opportunity for you to be engaged as a partner, to actually be at the table with us to help with some of the decision making. And last but not least is knowledge mobilization. What do we do with the information that we collect? You know, as a scientist, I publish papers, right? You know, that's what allowed me to advance in academia, is publishing papers allowing. But who reads those papers? Really, I'm speaking to my peers. So if I really want to get the information out about the studies I've done, we need to mobilize that knowledge differently. We need to make sure we're communicating those information in our town hall forums, communicating the information on radio stations, on YouTube channels, in ways that the community can hear the advances that science is making and how that can impact them. Next slide. I'm almost done. I'm going to take another 10 minutes. And then after that, we're going to open it up to questions, make sure we have time for some dialogue. And when we think about how do we operationalize engagement through our trusted partnerships, this is just an example. Work with the BGLC, the Black Greek Letter Consortium, where hosted over 63 events. And they had over 6,312 website visits. That's an example of outreach and engagement. And then also through the BGLC, they had a program called Rooted in Resilience, where they had over 593 participants for the community day, and they had over 9,200 individuals for the Sunday church day. So you look at the impact that our communities have, and our partnerships with DREF, the Delta Research Education Foundation, the Black Greek Letter Consortium, and the Cobb Institute, and the National Black Nurse Association, where we've been able to collaborate to have over 575 real engagements that led to actually enrollment. Then our participants as partners, as I told you, if you look at our participants as partners, you see that those participants represent the diversity of the U.S. And last but not least, again, knowledge mobilization. An example of thinking outside the box is the way that Zeta Phi Beta sorority hosted What's for Dinner. It's an event during American Heart Month, where they educate nearly 200 individuals on how family medical history and traditions impact community health and individual medical history and how this relates to the program efforts. That's an example of knowledge mobilization, how we've leveraged the trust and the work of community-based organizations to do this work. Next slide. And I cannot have this conversation about research engagement without talking about the importance, the continued importance of engaging our historically Black colleges and universities. And right in the California area, as you all know, you have Charles Drew University School of Medicine. And I'm very happy to have worked and to be working with several people at Charles Drew, like Dr. Roberto Vargas, and work that we're doing to be even better engaged Charles Drew. But one of the things when you think about this concept of equity, we had to say, do our HBCUs have the resources to actually be an equitable partner in this research? And to make sure that we're thinking about capacity building, we worked with RTI as well as Community Campus Partnerships for Health. CCPH is actually a community academic partnership international organization led by African-American male Mr. Al Richmond out of North Carolina. And CCPH has really been stressing the importance of engaging our HBCUs in research and faculty and students being engaged in research. So through our institutional champion support, we've supported over 13 HBCUs getting capacity building built to support them being engaged in precision medicine and genomics research in all of us. And here's a quote from one of those researchers at North Carolina A&T, Dr. Exford, who said, having access to the All of Us data set helps level the playing field for HBCU researchers like myself. Next slide. Now, what type of data do we collect? So like I said before, we collect surveys, electronic health record, physical measurements, wearables, and that the biological data includes also genomic data. But one question we often get asked, well, Kareem, where does that data go and how is it protected? And when you say people have access to that data, what does that mean? We have a researcher workbench where that data is housed. It's housed on a very secure cloud-based tier, and it's housed in an aggregated way, meaning that when you enroll in the All of Us research program, I'm enrolled as a participant and I work for the program. And I'm not Kareem Watson when you look at my data in that program. I'm number so-and-so with some other non-identifiable marker that lets them know that this is my information and it's protected amongst very secure measures. And within that workbench, we have that's data available to the public, that's through a publicly available data set. But we also have registered tiers where you have to go through a certain amount of training to get access to that data. And you have to be affiliated with an organization that signs a data use research agreement saying that you agree to the research rigors that we have put in place to make sure that you're not conducting research that is unethical, that's going to produce data that may be polarizing and other things. So those are the way that our data is protected and researchers have access to that data. Next slide. And I want to end by highlighting a few examples of research that's taking place in our workbench. This is a project done by Dr. Naia Noel, who's an assistant professor of medicine at Boston University. Dr. Naia Noel's project is so important because it's looking at this concept of high-risk maternal mortality in African-American women, looking at high blood pressure. She's looking at leveraging the All of Us data set to study high blood pressure disorders of pregnancy and the impact of uterine fibroids and untreated fibroids. So Dr. Noel is able to do this study because of the size and diversity of our data set. And it's so important for us to address the issue of maternal and child health when we think about moving research forward and health equity and inclusion. Next slide. This is another study looking by Dr. Wingate, who's a professor at Howard University, assistant professor. He's leveraging the All of Us data set to study the risk of food insecurity among cancer survivors. His study assesses whether the likelihood of food insecurity varies amongst individuals with high blood pressure when taking their prior history of experiencing cancer into account. His research hypothesis is that individuals with high blood pressure who survive cancer are more likely to experience some degree of food insecurity in comparison to individuals with high blood pressure who have not had cancer. So these are so important, such important questions being asked by amazing researchers. Another example on the next slide. This next example is a research on social determinants of health being led by Dr. Cheryl Clark, Associate Chief of the Division of General Internal Medicine at Harvard Medical School. Dr. Clark co-chairs our All of Us research program, Social Determinants of Health Task Force. And she has led this work to ensure that our participants report on social factors that influence health. So the quote here is that the demographic and geography diversity from the participants' data provide a key resource in identifying patterns that may inform disease and allow us to better understand risk factors. Next slide. So partner with us. This is just a slide. This is actually an invitation for you to partner with us, to learn how you can be a contribute, to learn how to be a participant, to learn how to be a community partner, or just to learn more information about the research that's being conducted. Please use this QR code here. We love to hear from you. If you know of things that are taking place in your community that you say, Kareem, I think this would be a great way to engage All of Us research program, please reach out to us. I'm not going to open it up to questions. I know that the chat has been live and that I think there's a Q&A going on. So thank you all so much.
Thank you, Kareem, even though I have to get used to calling you that. But before we get into Q&A, open it up to the audience, we kind of have a little bit of a surprise, but I thought it would be helpful to actually have someone from our community who has actually enrolled as a participant in the All of Us program to tell her story and
Wow.
about why she actually chose to do that. And so I'd like to introduce Renee Wright Davis, who is a proud Cal Berkeley women's basketball alum, class of 2006. And after she finished Berkeley with a degree in social welfare and a minor in psychology, she went on to work at the University of California healthcare system for about 5 years. So she's very passionate about health and the community. And that passion pushed her or inspired her to go get her master's in public health with a minor in health promotion. So she's been doing a lot of work in the community to improve health literacy, address health disparities, help uplift the community, and do a lot of other things, which in the interest of time, I'll just let Renee tell her story. So Renee, I'll turn it over to you.
Hi, everyone. First, I just want to say thank you to Rhonda and CBHN for having me on today. It is an extreme pleasure. And Dr. Watson, everything that you said as a public health nerd and advocate, amazing. Absolutely love it. So I'm really excited. I kind of have always felt that my life is a testimony for helping others in our community. And for me, being a first generation graduate, just pretty much everything first for my family has been a driving force for the reason why I am doing everything that I'm doing. And so when I got the opportunity actually from UC Davis Health System, I just finished a visit with my primary care doctor, and I got an email asking if I would be interested in the All of Us program. And I said, okay, let me do some research on this because, what you had touched on earlier, Dr. Watson, about the cultural mistrust and of the system. It's like, okay, who am I really giving my data to? And do I really want this to be a part of my life and my family's life? And so after some research, I was like, you know what, this is a great program and everyone should be a part of it. So I ended up signing up, and I just really wanted, one, my mom has been through a neuromuscular type of disease. We still don't know what exactly it's called. And we have some family history of heart disease and just all of these different chronic ailments and illnesses. And so knowing that I could be a part of this program and help identify this for my kids and for their kids was something that was a huge driving force for me to create that generational change. So once I decided that I was going to be a part of this study, UC Davis sent me a link to sign up through the All of Us program, which is on an app, which is really nice because I can consistently refer back to it and see all of my assessment information. And so once I signed up, I included my demographic information, my medical consent, just step by step, it was consistently asking me, do you consent to sharing this information? Let me explain what this means and why, which I found very refreshing. So that process was very easy to go through. And then I scheduled a physical assessment that was in person with one of the All of Us researchers at UC Davis. It was about 45 to 60-minute assessment appointment. And during that assessment, we took my body weight, we did measurements of my body. I also did some lab work. And the thing that was really exciting to me when I found out that I was doing my lab work was that from my blood sample, I was able to do a DNA analysis and get some of those results. So I was like, well, maybe from my lab work, I'll be able to help diagnose what's going on with my mom. So I was just really excited about that piece. So after my assessment, I received some follow-up information, once again, just making sure that I consented to my data being shared and that I did want to participate in the All of Us program. And there's many activities that are associated with it as well. Like now there's a mental health program that's a part of it where they can assess your behavior and your personality. Also, there's some movement activities that are a part of the program too. So it's very informative and impactful. But one of the things that I like really enjoyed was when I actually received my DNA results. It took about 6 to 8 months for me to receive them, but in the scheme of things, knowing that it's a national program, that's a pretty quick turnaround time to like find out the amount of information that was provided to me. And so within my DNA results, it actually provided me my hereditary disease risk medicine in my DNA, my genetic ancestry. Some cool things that I never would have thought you could test for was like your bitter taste assessment. So based upon like your ancestry, it allows you to determine what things might taste more bitter to you compared to like what might taste bitter to someone else. And so we're all different in that way. My earwax type was really cool thing to learn. I'm a boy mom, so like it was nice to like share that information with my boys and they're like, oh wow, that's so cool. And then lactose intolerance. So like dairy is one thing that I've always struggled with, but I wasn't 100% sure if that was a part of my genetic makeup. And so having that confirmation actually provided me the information I needed to make sure that like I am dairy sensitive. So I need to like make cognitive decisions if I choose to have ice cream or different types of ice cream that don't have dairy. And then a part of all of that information that was provided to me, there was a learning center within the app and the program itself. So all of my results that I received, I was able to do some further digging to have a better understanding of why these results were important and what did it mean and how could it help me live a healthier lifestyle and how could I apply it to the whole mind, body, spirit, health, and then being able to advocate with others in the community. And so one of the pertinent things that I learned about, because my family does have a history of hypothyroidism, is the medications that my body metabolizes versus the medications that my body has trouble metabolizing. And so making sure that I'm advocating for the correct medications that work for me personally, instead of just accepting that blanket medication that's given for everyone. And so that really empowered me to have a different conversation with my healthcare provider and then make sure that I'm tracking better the type of side effects that I'm experiencing as a person. And as far as the hereditary disease, um, spoiler alert, it didn't tell me exactly what's going on with my mom, but it does help me to be able to share some of the hereditary diseases that my family is susceptible to, and that I should be educating my sons on and having my history chart so that they can watch for it themselves. So all of this information and being a part of the program has definitely been a win for me. I feel like it's made me more proactive in taking charge of my care, but also being able to advocate for my mother and my father since I'm their caregivers. I've been able to have different conversations with my healthcare providers where I'm not actually allowing them to talk at me, but we're having a mutual conversation and from a knowledgeable approach as well. And then the last thing too is just getting ahead of like any health issues and preventing them from really taking that stance of becoming a chronic illness or something that's debilitating for me. So I cannot champion enough being a part of the All of Us program. I'm one of those people that if I'm going to advocate something or tell someone to do it, I'm going to do it myself just to make sure that I'm giving correct information. And it has definitely been beneficial for me.
Great, Renee. Thank you so, so much for agreeing to be here today and for sharing your story. That was amazing. And
Renee, you got to go on the road with me. I can't do this. If I would have known you were here, Renee, I would have been quiet. I would have stopped talking 10 minutes before because I want to hear more from you.
Yeah. So it was a surprise guest, right? And so I know there's a lot of questions. It seems like chatter in the chat. So I'm going to ask Aaliyah to tell us one of the questions that's in the chat. So I don't see anything in the Q&A box. Something just popped there, but Aaliyah, what questions are in the chat for either Renee or Dr. Watson?
Hi, so Desiree Campbell asked earlier, and she said, "This is such important work. I would like to see how we are working with urban areas of the intercities."
Yes, thank you so much for that. That's a great question. And I'm really happy to say that we've actually done really well in the urban areas. What we have to do better at is in the rural communities. So like I said, Detroit, Michigan is one of our partners for Enrollment Center through Henry Ford Hospital there. Several of the urban areas in California, as you saw, Chicagoland area, we're well represented. And the list goes on. We now have a site in St. Louis. So doing really well in the urban areas, a big site in Atlanta with Morehouse School of Medicine and Emory Health Center down there. Where we have to do better is in the rural communities, those populations who don't have access. So really doing well in the urban areas.
Thank you. I have a question in the Q&A box. Kimberly Thompson wants to know, is there an age restriction for participation and can patients enroll their children? She would like she would with pediatric and adult blood cancer patients.
Great question. And I'm so excited. As a former scientist who designed research studies, one of the things that prevents a lot of underrepresented communities from enrolling is this thing called inclusion and exclusion criteria, meaning that before we even enroll, the study has criteria that we don't qualify for. Thankful that the All of Us study right now, the only criteria to enroll is to be 18 or older with the ability to to participate in the informed consent process in English or in Spanish. Right now, we are on the journey to looking at engagement across the life course, meaning that we will soon be talking about how we will make the plan for enrolling families and enrollment across the life course, and that will at some point include children.
Great. And Aaliyah, is there another question in the chat?
Less so a question, I don't know if this would want to be personally attended to, but Sheila Marchbanks said, "Hello from Southern California, living as an elder sickle cell disease warrior. Please let me know if my participation would be a good fit for this program."
Yes, yes, yes. I'm working with this sickle cell disease organization here in Illinois, because when the new FDA approved drug came out, I reached out to one of my former community partners right away, and I said, we need to make sure that people living with sickle cell disease and their families are enrolled in our program so that their data can be a part of this analysis and we can begin to track how they're responding to medications and doing so. Yes, and like I was saying earlier, and Renee alluded to this as well, in some studies, having a disease or a condition will exclude you from being involved. There's no, that having a disease or not having a disease in All of Us does not exclude you. People with cancer, high blood pressure, sickle cell, diabetes, or people with no conditions can enroll.
Great. And so Tia, hi Tia, wants to know, how can someone help connect Dr. Watson and CBHN with other community-based organizations to present this info? So maybe Dr. Watson, you can come to California and we can do a tour across the state, you know.
Yes, yes. And
we could just, you know, travel in other ways across the state.
If one of my colleagues had their way, Sheila James, one of our program officers, we have a mobile engagement asset, which is a mobile home that goes across the country. I know Sheila would have the mobile home in California as much as possible. But so I would love to talk about ways that we can think about making sure that our MEA engagement, which is again a mobile engagement asset, thinking about those parts of California. We're so thankful. And I saw one of our foreign participant ambassadors and one of our partners from one of the sites on the call in the chat too. So thankful that California has a large presence, but I still do understand the rural communities of California that may not be represented through some of the academic partners. That's where our MEA, our mobile engagement assets, really become important.
Yeah, I do know Sheila, and I have talked to Tom about coordinating a schedule for the mobile coach. So I need to touch base with Sheila anyway, so we'll see what we can make happen.
All right.
So Michelle Jacques wants to know, what does the research say or offer to a person with autism?
Great question. Oh my gosh, another area we have to do better. We're working with the American Association of Health and Disabilities, AAHD, which is one of our national engagement partner, to see about what can we do for participation by proxy, meaning that we have several parents of guardians or parents of adults living with certain conditions that may put them at certain decisional impairment, not autism, but that, and so participation by proxy. So I have to go to our workbench, and that's one question I can follow up on and see if there's any research being done on autism within our workbench. So I would definitely look that up. But I'm so excited for the opportunity. If there's not a current project looking at autism in our workbench, I will hope that a researcher, I saw there was a PhD student from UCLA that signed on board. Hopefully that graduate student is interested in looking at our data set to ask some research questions as well.
Okay. Aaliyah, is there another question in the chat?
Sheila Marchbanks asked MEA ? Please share again what this is. Thank you.
I'm sorry, say that again.
Oh, Sheila James answered, this is our mobile unit.
Okay. Okay,
So
great.
there might be questions in the Q&A now.
Yeah, and I saw there was a question about a comment rather about UC Riverside. I believe that's UCR, right? Is UC Riverside?
Yes.
Okay, I'm learning that their School of Medicine has a special program. Would love to connect with those medical students about researcher access.
Okay, so we actually have a relationship and partnership with UC Riverside School of Medicine and working with Dr. Osei, who oversees the Prime ABC program at UC Riverside. So happy to facilitate that connection. And actually, we have about 4 of the Prime ABC students in our health equity advocacy training program this year. So
awesome. Congratulations.
Yeah, thanks. So yeah, we got quite a few questions in the chat now. So this is from Sheila Brooks Lafridge. As a local nonprofit focused on diabetes and bringing equity to healthcare, is there a space allowed in the conducting of research and obtaining the research training for non-healthcare professionals to gather and submit data?
For non-healthcare professionals. Yes, that is so important for partners. Right now, one of the challenges we have 3 levels of that data. One is the public tier. Anyone can do who has, and I want to say anyone who has internet access. I don't want to make the blanket statement of the assumption that internet access, everyone has it. So anyone who has internet access can access our public data. But in order to get to the registered tier and the control tier, you do have to be affiliated with a not-for-profit currently, or an academic medical center, because you have to go through that Dura registration process. And one of the things about analyzing our data is that you have to know a coding language called R or Python. We soon will be putting SAS in there, but right now it's just R or Python. So that does limit how community members, how nimble, if you will, they can be within our data set. But the beauty of that comes in the partnership, right? Partnering a community member with an academic partner where they can ask the questions that are important to that community member together.
Okay,
I
great.
hope that answered the question.
Yes, I think it did. So Marian Wally asked, does all of us conduct studies on patient-doctor communications? Doctors following up with patients about lab results and other tests in a timely manner.
I don't know if that direct study is in there. And again, we can have a follow-up, Rhonda, with what studies are in our researcher register, in our directory of research projects. I do recall that there was one project that looked at how some patients, if they were adherent, if you will, to a physician's recommendations for certain screening, and that was by looking at the electronic health record. You may see in the health record there was a recommendation for screening by the physician, and you can then see if that participant, adhered to that. But there is also a question in the social determinants of health survey that talks about a participant's experience with the healthcare system.
Mhm. Great. And if we have time, I want to touch upon something
Okay.
related.
I got about 6 more minutes. So.
Okay, great. We got one more question in the chat. I'm sorry, in the Q&A box. And this is Josh and Phil from Aligned Community Physicians. We would just like to say that we definitely appreciate and support this. Thank you, Dr. Watson, for your stance on acknowledging that we all are different, ancestry, diet, behavior, and may require different approaches to wellness. So thank you very much, Josh, for putting that in the Q&A box. So Michelle has another question. What about connections with other researchers and institutions such as City of Hope and particularly African-American physicians? So I don't know if you work with the NMA at all.
We do. We work with Cobb Institute, so Cobb Institute is the research arm of the NMA, the National Medical Association. And for the past couple years, I've actually attended the NMA convention and presented to those researchers. And I would be remiss if I did not thank Ms. Jessica Walker from the Community Council of Greater Dallas, who brought on CBHN as one of their partners and sub-awardees to make this happen. So it is because of Jessica Walker and the Community Council of Greater Dallas that I am here and that we are here. Just another example of the reach of our CPGI network and our partners. So Jessica, thank you so much.
Great. And then, well, I guess we'll take this as one last question for you, Dr. Watson. And this is from Natasha. As a local nonprofit focused on maternal health and infant mortality, specifically linked to social determinants of health and implementing a consortium to address these social determinants of health, how could their organization utilize the program? Great question.
That's great. One of the ways is really thinking about if you had access to researchers that may be epidemiologists or even other physicians or students that would want to look at our database. And, one of the things at the control tier, we actually have 3-digit zip code level data. So you could look at, information that's specific to California and look at women in the California area and, looking at EHR for looking at birth outcomes to see, are there differences based on that 3-digit zip code area, right? Are there differences based on how you answer that question around socioeconomic status, ethnicity? So there's so many different ways that our database can be used to really disentangle a lot of the issues that have gone into maternal and child health.
Great. So I think we've run up against that 6 minutes that you had left. So I want to say thank you again, Dr. Watson, for your time today. Renee, if you can hang on, I do have a question for you. But thank you again, Dr. Watson. We will be touching base sometime in the next few weeks. So if you have to go.
Thank you again. And Renee, thank you. And appreciate you being here
you.
again, Rhonda. And again, thank you to Jessica and the Community Council of Greater Dallas. Thank you all.
Yeah. So thank you. Have a good night. Okay.
Bye-bye.
And then Renee, I think you said something that was really, really important about how you utilize the information that you received from all the testing that was done as part of your enrollment. And so, as you know, we were working on igniting a Black health movement here in California, and specifically through the work that we are doing with the How Do I campaign. And so one of the things that we talk about, right, is how to have a conversation with your healthcare provider. And I'm really happy that you brought that up, and how information and knowledge is power, and how we can really control somewhat of the narrative, but definitely the conversation, right, that we have with our healthcare providers. So thank you for bringing that up. I don't know if there's anything else you want to talk about that. And I think the other important thing that you said is getting ahead of diseases, that those that are preventable. So I don't know if there's any additional information you want to share about that and your experience.
Yes. Thank you for bringing that up too, Rhonda. I really do love, so the Health for All, the How Do I campaign that's happening is monumental. Just being able to understand the resources and the tools available. So now, before, when I would go to my visits, or even for my visits for my parents, I would just kind of show up and, let the doctor talk to me and see what what comes out of those conversations. But now we've actually gotten to the practice where we write down what is our intent for this appointment? What do we want out of this appointment? What is our priority that we want our doctor to address? And when we're walking out the room, what do we feel we have accomplished? And then, is this the provider for us? And so now going in with like pre-prepared questions, it does allow me to feel more empowered to control the narrative of the conversation. And it allows me to which we shouldn't have to do, but there's times that it does happen, to show that I have a medical understanding and that I know what's going on with me in particular, or my parents when I take them. So the conversation and the way that the doctor looks at me is completely different than me just going in as a patient with a complaint and then looking at them to say, okay, so fix me.
Great, great. So yeah, so we're, as you know, we're going to be doing more of that broadly across the state, as well as going to communities to have these conversations, so that we can have everybody get to the place where you are, right? And
Yes.
can really own that power and that dynamic between themselves, their provider, and the healthcare system. So thank you so much for sharing your story.
Thank you.
Okay, and then if we can, so I know it's a little bit over time, but Ambria, if you can bring up the presentation, we'll just wrap it up and let people get back to work or whatever they were doing before the webinar today. So thank you, Renee. And presentation, please. If we can get that back on the screen. There we go. Thank you very much. Yes, so just wanted to make an announcement and share some upcoming events that we have, not necessarily hosting, but definitely participating in, well, a little bit of both. We are participating in the SoCal Women's Health Conference in March. So we'll be there really talking about some of the work that we're doing in the environmental justice space, specifically around the Non-Toxic Black Beauty Project that we're working on. We'll do training also on March 28th. That is related to mercury and skin creams, especially for communities that are using skin lightening creams, and the harmful risk associated with that is because of the mercury content in those products. And then we will be hosting a couple of Black Health Network member meetings coming up in March. March 7th will be in LA, but I think that's virtual now, thanks to rains and some of the damage that were incurred by the heavy rains over the past weekend. And then March, we are going to the Inland Empire to do something for Riverside and San Bernardino counties. And then we're doing something in San Diego in March, but we have yet to nail down that, May, but we have yet to nail down that date. So next slide, please. So you can connect with us. You can register for all the events that we're having on our website. If you go to cablackhealthnetwork.org under events, all the current events will be there. The recordings for any of the webinars, and especially today, will be on our website in the archives, and also on our YouTube channel. So you can connect with us on all our social media platforms. That's Facebook, LinkedIn, Twitter, now X, we got to update that, and then on Instagram as well. You can also join us and support the work that we do through the Campaign for Black Health Equity, and become part of the CBHN family. You can become a member. It's no cost to become a member, but there are lots of opportunities to benefit from some of the things that we're doing and offering through our member network. So last and final slide, I just want to say thank you all for participating and attending the webinar today. Don't forget to fill out the evaluation form. If you do both the pre-evaluation or pre-assessment and the post-evaluation, you enter to win a $50 gift card. And bless you too, Mike Browning. Thank you very much for coming today. Please spread the word about this important program and why our community needs to be part of it. So I really believe that patient empowerment and really taking ownership of our health and wellness is going to be the key to help closing the gap in health disparities. So information and knowledge is power, as Renee was definitely a great testimony for that. So thank you all again. Have a great afternoon or evening wherever you are, and we'll see you next time. Take care.